Good evening. So I'm going to talk today about sex, relationships, libido, things that maybe many of you haven't spoken to or thought about before. It's Valentine's Day round the corner, which I actually think is a bit of a commercial annoyance. I think we should be thinking about our relationships every day. We don't need a special day to remind us about how important relationships are. And actually it was only when I started my clinic 8 years ago, I included on the questionnaire that we give to people, I included a question about libido. And it means that women are prepared to, or they're going to expect for me to talk to them maybe about libido. And it's also for me to acknowledge that it's actually really important to talk about. And so I've had obviously an extensive medical training. I was taught, actually I was very privileged in the 80s. We had someone in Manchester who gave us as students some really good lectures about libido, about sexual relationships. And as a teenager it was all a bit laughable, or we were always a bit awkward in the lecture theatre listening. But actually it's so crucial, and I realise more and more that it's so important that as healthcare professionals we can talk about anything in a very non-judgmental way and also a very confidential way to our patients. And so many women and men, actually, when I was a GP, but certainly women in my surgery, have told me so many things that they haven't even told their partner. So I just wanted to share some information really about hormones can have an effect on our libido, our relationships, and also sex too. So we know that there are lots and lots of symptoms in the perimenopause and menopause when our hormone levels are changing. And as I've said to you before, actually they affect us in many different ways. But we know our hormones affect our brains. And when I'm talking about our hormones, I'm talking about estradiol, progesterone and testosterone. Now they're called the sex hormones, but they're not really about sex. And they're not even about gender, because men have estradiol, progesterone and testosterone in their bodies and in their brain as well. But clearly I'm going to be talking about these hormones with respect to the perimenopause and menopause, when the hormone levels fluctuate and change in the perimenopause and get very low in the menopause. Now, our hormones work in different ways, as you know, and they affect people in different ways. But the commonest symptoms we know from people from using the Balance app, the free app, when they monitor symptoms, the commonest symptoms are anxiety, poor sleep, reduced concentration, low mood, anxiety, low libido, and weight gain can be very common as well. So even if we're not thinking about libido at the minute, if you think about the commonest symptoms, in fact it did happen to me, so when I was perimenopausal, but like a lot of women, if you're feeling tired, if you're feeling anxious, if you're feeling irritable, if you're feeling more depressed, lower in your mood, then the last thing you're going to think about is jumping into bed with a partner or starting a new relationship. You might have low self-esteem, feeling of reduced self-worth. It's very, very common during the perimenopause and menopause. So you're not going to feel like stripping off and being really intimate with a partner. A lot of people also have weight changes. A lot of people put on weight during the perimenopause and menopause, and I've spoken about this on a previous Instagram live. And so there are lots of sort of physical and psychological reasons why our libido might change. And then also our libido in women and men actually is not just a hormone, it's not just a one thing, it's a combination of factors. And when we're looking at libido and if it's reduced and trying to work out, is it a physical thing, is it a psychological thing, is it a social thing, it's often a combination of things, and everyone's different. So obviously the advice I'm giving is really generalised, but we do know our hormones, certainly estradiol, but especially testosterone, can have an effect on libido. But when I say libido, what does that really mean? If you look at Freud's definition of libido, it's more about a pleasure of life. It's not just about a sexual pleasure. And so I think we should be talking a bit more broadly when we think about this libido, because I want to be opening the curtains in the morning and seeing the sunshine and being happy. I want to enjoy my day. I want to feel good about myself. I want to feel good about others. That is libido as well. And then it's having a special connection with a person. Usually it's one person, but people vary, of course. But having that the idealization and thinking about sex is really important when we think about libido. Now, libido is going to vary throughout the day, throughout the months. Of course, it depends on so many things. But there are a lot of women when they're perimenopausal or menopausal have no libido. And I know some of you who've asked questions have specifically said that they have zero libido since they've become menopausal or perimenopausal. They have no interest in sex at all. And actually, just to reassure you or worry you, depending on how you think, it can be very, very common to have low libido. And a lot of women I see in my clinic haven't actually had sex for the last 2 or 3 years. A lot of women tell me they really still love their partner, they still want to be with them, but they have no interest at all in having sex. And they've tried all sorts of things and nothing has really helped. And sometimes it can be related to a hormonal balance. And how do we know that? Because when we give HRT back and we give testosterone back in physiological doses, then actually people then say, nothing else has changed in my life, but my libido's improved. I now feel like having sex, and when I have sex, it's really pleasurable. Because there are also quite a few women we speak to who are still having sex, but they're not enjoying it. A lot of women say to me, I just feel numb from the waist downwards. I go through the motions, but it doesn't feel like anything joyful at all. And so we know it can be related to hormones, because if the only thing that's changed is replacing the hormones, then that is going to make a difference for some people, not everybody. So I don't want everyone to think that rushing onto hormones is going to improve your libido and improve your relationship with your partner. Of course, there are lots of reasons, but this, when we're looking at the multifactorial all the factors that are contributing to libido, then hormone deficiency is often part of it. And it's often, for a lot of women, say it's not until they've had their hormones, estradiol, progesterone, but especially testosterone, rebalanced, do they start to feel better and feel that sex is more pleasurable. Now, obviously, even sex can mean different things to different people. It doesn't necessarily mean penetration, and it might not be sex with a partner. It might be self-masturbation, or it might be sex with a same-sex partner. I have quite a few patients who are in same-sex relationships, and you can imagine if there's 2 women going through menopause or perimenopause at the same time, then that can be actually really difficult too. So talking is really important about how you feel. And I'm really quite shocked, but more saddened actually, with a lot of stories I hear of women telling me that they don't feel like having sex, they've got no libido, when they do have sex, they don't enjoy it, but they've never spoken to their partner about it. A lot of women tell me that they go to bed early, they pretend that they're asleep, they tell their partner that they have a headache, they do anything they can do to get out of having sex. But rather than talking about that they don't feel like it, that something's changing in their body. And that's really important, especially if you're in a stable relationship, which a lot of women tell me they've been married for many, many years, but they find it really uncomfortable to talk about to their partner. But we also have to remember the impact that our perimenopause or menopause might affect our partners. So I used to do a lot of work with West Midlands Fire Brigade, which were mainly men, of course. And a lot of men in their 40s and 50s, when I'd give them education and information about the menopause, they would then say, oh my goodness, I thought it was me that she'd fallen out of love with. I had no idea what was going on, because I'd go home after a long shift, working really hard, and she'd be slumped on the sofa. She wouldn't be happy to see me, she wouldn't engage in a conversation, she'd avoid talking to me, she'd go to bed at different times, and I just thought we were drifting apart. I had no idea that the menopause could do this to me. I had no idea it could change the way her personality was, the way her view on life was, the way her interested in things were, even her eating habits or her physical appearance. So it's really important that when we're looking at libido in relationships, we involve the partner as much as possible as well, because we have to see it from their side as well as from the individual that's suffering. And sometimes when the perimenopause or the menopause creeps on us, it might just be gradual, subtle changes that occur, and you're not realising the impact it has on the person who's closer to you. And it is human nature. We often take our emotions out on someone who's nearest and dearest to us, which is usually someone who we love, who we're having an intimate relationship with. So it's really crucially important that we can share the knowledge and information. And also, if partners have more information about how the perimenopause and menopause can affect people, they actually might be able to pick up symptoms and understand what's going on before the individual. Because when you're living in your body, you don't notice subtle changes the same, whereas others externally might notice. So hopefully you can realise that there are lots of psychological symptoms, there are lots of mental health symptoms, but there are also physical symptoms that can occur. The other times, I don't often talk about flushes and sweats because although they are quite common, they're often not the symptoms that women come talking and complaining about. But I do have people that have a lot of vasomotor symptoms of flushes and sweats, and one lady a few months ago told me that every time she even held her partner's hand, she just felt that it triggered this big flush going from her head to her toes. She was dripping in sweat. It was really unbearable. So she said there was no way that I could even hug him or have sex with him because I knew that I would just be a ball of sweat and as hot as a fire, and it would just be awful. So there are other, there are sometimes people who have the flushes or sweats. Also, I have some people who have or some ladies have a lot of muscle and joint pains. And if you've got muscle and joint pains, walking up the stairs can be difficult. Just doing your washing can be hard. The last thing you necessarily want to do is to jump into bed and do having sex in a more physical way. Might actually be quite difficult just because of the joint and muscle pains. So there are all sorts of reasons, but the most important thing is to talk to somebody about it. And I'm really quite shocked when I speak to women who have spoken to lots of healthcare professionals over the past, but either a lot of women say, I've tried to talk about sex, but it's been really uncomfortable, or the doctor hasn't brought it up and I thought it wasn't my place to talk about. We are all trained. We should be able to talk about sex. So it is important to bring it up in a conversation with your healthcare professional. Now, the other reason why people might find that sex is uncomfortable, so they might have libido or they might not have, but they might find that actually they have vaginal soreness and dryness, and so actually having penetrative sex can be very, very painful for some women. I have done an Instagram live all about genitourinary syndrome of the menopause, which you can watch on my Instagram live, but actually they're all uploaded on my YouTube with subtitles. So if you look at my YouTube, Dr. Louise Newson, you can look at previous Instagram lives, which you might find helpful. But when we have low estrogen and testosterone levels, it can cause thinning of the tissues, especially in the vulva, the vagina, the clitoris, and the surrounding tissues. And as I've said before, if you can imagine, our vagina is supposed to stretch because when we walk, it's supposed to stretch. It's not supposed to be this stiff object that doesn't stretch or is uncomfortable when we're walking or moving or sitting down or riding a bike. But during the menopause, when the tissues become thinner, they have less collagen, they have less of the elastic fibres, they have less blood supply going through. Then the vagina can become very thin, very fragile. The tissues can become more they can just break down easier, and all of that can lead to soreness. Sometimes it can lead to bleeding after sex as well. And you can imagine if you've got atrophy, so thinning of the and reduction in size of the clitoris, then it can't be stimulated in the same way. And a lot of people actually say they think their clitoris has disappeared. And this is all changes due to the menopause and perimenopause, due to hormonal changes. Some people find externally that their vulva changes, so their labia minora and minora look very different and become thinner. And that might be quite shocking actually, because often with relationships, as I've said before, many women don't actually know what their vulva looks like. There was a great thing a while ago I saw where people had photographs of their vulvas. There's about 100 women and they were all put up on a wall, and people were asked to recognise which is your vulva, and loads of women got it wrong. If it was about men and penises, they probably all get it right, but obviously it's easier to see a penis. With a vulva you have to use a mirror. So quite a few partners might know the anatomy of their partner, especially their vulva appearance, more than the person. So they might be quite shocked to see that it's changed. So again, this is why talking is really important, so you can share what changes are going on in your body. But if you are noticing that having sex is more uncomfortable, if it's painful in any way, if you feel that you've got less lubrication, if it feels drier, then actually that might be a sign that you've got some of these genitourinary symptoms due to the low hormones. And this is where treatment is really important. So there are vaginal lubricants and moisturisers that can be used. Now, a vaginal lubricant is usually just used when people are having penetrative sex, but there are loads of them and you have to be really careful what you use. So if you go to a pharmacy, you'll see the shelves are covered with them, and sometimes they've got different scents, they've got different tastes, sometimes they've got different looks or colours, or there's some with glitter on, there's all sorts of things. But actually, do you really want that in your vagina? Don't think so. You have to have something that's as neutral as possible. And so there are some companies, and I don't work with any of the companies at all, but some companies do make some that are just purer and calmer than others and are less likely to irritate. So yes, do a vaginal oil-based and a water-based lubricant, and they also do a vaginal moisturiser as well. And they're sort of one of the go-to companies that I would go to, because they've been tested well and people find that they don't irritate and cause discomfort. So it's worth looking at those. A lot of people go to something called KY jelly because we often use it in an examination room, but it's very drying. So it might be fine for a quick examination, but not if you're going to have prolonged sexual intercourse. So if you get any discomfort, then it is worth looking at alternatives. But that's not going to treat the underlying problem. It's just going to provide some moisture and some lubrication at the time. Because the cause is due to low hormones, usually estrogen and testosterone in the area, then using vaginal hormones can be really transformational if you're having painful or uncomfortable sexual intercourse. So we, as I've said before, we can use vaginal pessaries, vaginal tablets, vaginal gels, vaginal creams, and they all they are available on the NHS. They all contain estrogen and they're used in different ways, and sometimes we use a combination. So we might use a vaginal pessary or a vaginal tablet as well as using a cream or gel externally, depending on the situation. And there's also something called prasterone, and I know some of you have asked. So prasterone, the other name in the UK is Intrarosa, and it contains DHEA, which is a precursor hormone, and it converts to both estrogen, estradiol, and testosterone in the vagina. It's a daily pessary. It's quite a sort of oily pessary that women usually insert every morning, but it will convert to those two hormones in the vagina. And what's really good about that is that it will stimulate the testosterone receptors and the estrogen receptors in the vulva, the vagina, the surrounding tissues as well, which is really important. It can sometimes take a few weeks, even a few months, to really have a maximal effect. So you have to keep using them. And you can use vaginal hormones whether you take HRT or not. And about 20% of women taking HRT will still need to use vaginal hormones, and that's important to consider. So if you are getting a discomfort or pain and it's not improving with your hormonal treatment, then go back and talk about alternatives, and make sure if you're using HRT, the right dose and type of HRT, often with testosterone, can make a difference to the genitourinary symptoms as well. Sometimes vaginal hormones aren't quite enough, and if you use vaginal hormones, you can still use vaginal lubricants and moisturisers. So we're all different, but make sure you talk to someone by looking at all these options. There are some women who get urinary symptoms, especially after intercourse. So there's a lot of people who have cystitis, the so-called honeymoon cystitis, where they get more prone to urinary tract infections after sex, or cystitis. And again, even if you're not having any vaginal soreness or discomfort and you're just getting urinary symptoms, it's probably related to the low hormones in the vulva and vagina. So you can still use these local hormonal treatments for for urinary symptoms. And I wish I'd known that as a GP, because I used to sometimes give people antibiotics to take after they'd had intercourse to try and reduce the incidence of a urinary tract infection, which can work. But of course, you don't really want antibiotics unless you don't really want antibiotics if you can get away without them. You're actually always better in medicine to treat the underlying cause. So using vaginal hormones can be really useful for the local vaginal symptoms and or the urinary symptoms that can be associated with sexual intercourse. But it can take a little while to have an effect. So don't be too alarmed if it's taking a while to have an effect. The other vaginal estrogen preparation is an estring. They're at short supply at the minute, but it's a little silicone ring that inserts in the vagina, and it can last for 3 months. When it's in, it's a personal preference whether you want to keep it in or take it out when you have sexual intercourse, and it's designed that it can stay in. Some people prefer it out, but it's just something that you know that there is an option for you. So looking at those treatments is really important. Now, there are some people who find, like I say, have anatomical changes to the vulva, the vagina, the surrounding tissues because of this shrinkage that occurs without hormones. They are reversible. So I've seen a lot of people when I've examined them and things have really changed. I can't see their clitoris. They've got some the shrinkage, if you like, of the labia, of the labia minora and majora of the and the vulva. And then after normally a few months of local treatment, sometimes with HRT as well, everything does come back. And that's the same with the clitoris. So a lot of people, when they talk in a negative way about testosterone, worry about clitoral enlargement. Now, I've not seen anybody, and I've not heard any of my patients talk about a clitoral enlargement that worries them. What I have heard and listened to patients telling me that their clitoris has basically gone or vanished, or they can't stimulate it when they're perimenopausal or menopausal. When they use vaginal hormones, sometimes with HRT and testosterone, they find that their clitoris comes back, so they can feel it, they can see it. It can be stimulated in a different way, or stimulated in a way that they didn't have before because it had gone because of being perimenopausal or menopausal. So just to reassure you, really, the anatomy can return, but it's using the right hormones, and often with a combination of testosterone, HRT and vaginal hormones can really make a huge difference. Now, a few people have asked about testosterone. I have spoken about testosterone before, and when we do testosterone, we do often do a baseline testosterone and SHBG level so we can work out the free androgen index. Now, this week I've spoken to 2 women who have been told their testosterone level is normal because the computer has said it's normal when they've asked for the results. When I've asked for the specific numbers, one lady told me that her testosterone level was less than 0.3. The other lady told me yesterday that her level was 0.7. Now, both of these are low. Of course, less than 0.3 means that she probably doesn't have any testosterone in her body at the time the blood test was taken. And so we have to, if you're going to have a test, ask for the actual numbers and see. And they are just a guide, but generally if your free androgen index is low, certainly if it's low than 1.5, it is going to be low, and taking testosterone might have an effect. Obviously, just using hormones is not going to have a transformational effect if we don't love our partner, or if we've got other stresses going on, or there are other reasons why we haven't got a libido or we're not enjoying sex. So of course, hormones aren't going to fix everything, but they are often a missing part of the puzzle. And we talk often about something called hypoactive sexual desire disorder, which I have mentioned before, HSDD, and it affects between like 10 to 25% of menopausal women. It's very, very common. We know that if people fulfil the criteria for having HSDD, then testosterone may help. But we do know that there's a very small number of women with HSDD currently able to get testosterone, because it can be very hard to get it accessed on the NHS. And hopefully that's going to change, because it is not just a natural hormone and it can make a big difference for a lot of people. So making sure that your hormones are balanced in the right way can make a difference. A couple of people have asked me about what if they have oral sex and they're using vaginal hormones. Well, you wouldn't put in necessarily, you wouldn't put in a pessary and then have oral sex within the next hour or two. But the hormones are very low doses. They're very, very low doses. So they're not going to do the partner any harm. If you have a female partner, obviously the female will have hormones. If you have a male partner, in fact, men have testosterone, estrogen and progesterone in their bodies. So it's not going to do any undue harm at all. And the same with if they have sex and some of the vaginal pessary or the cream or the gel gets on the man's penis. A bit of estrogen on the man's penis is not going to turn them into a woman at all. So you can really reassure them about that. And it's important to be aware. Some people worry that if they've rubbed on the gel and then they jump into bed with their partner, could the gel transfer from the female to the male, or the female to the female, or whatever? If you rub the gel in, once it's dry and your skin feels dry, it's not going to be transferred, and the dose of each pump is very low. So again, I wouldn't worry unduly about that. So I hope that's been helpful, going through really more about the hormonal changes that can occur during the perimenopause and menopause and affect libido and sex. With relationships, it's so important to talk and understand each other. I see and speak to so many women whose relationships have broken down during the perimenopause and menopause. And it's not until they've actually broken down irreversibly that they then understood that it's been related to their hormonal changes. Their partner didn't realise, and they didn't realise at the time, because when you're in the midst of it, it can be very difficult to take a step back and understand what's been going on. So really crucially important that we all get information. I'm going to put some resources on my Instagram Live that you can refer to. There's a couple of podcasts that are worth listening to. In my book, The Definitive Guide for the Perimenopause and Menopause, I've got information for partners as well, and also for families as well, because if you're shouting or having problems with your children, that is going to have an impact on your partner often as well. So looking at the whole picture is crucially important, but I really advise you to speak openly, talk to your partner before it's too much of a problem. The amount of horror stories I hear where people have been avoiding talking about how they're feeling, trying to distance, almost trying to protect themselves from their partner because of the way they feel, but longer term it's not going to protect, it's not going to help. We need to be cohesive and talk together, and if you feel you can't talk, then use someone else. There's some amazing psychosexual counsellors. I do quite a lot of work with the British Society of Sexual Medicine, and they are really amazing people who have a network of counsellors, psychosexual therapists who work closely with each other. And it's worth seeking out help, even if you go individually first or if you go together as a partner, to try and rebuild your relationship. If you haven't had sex for a long time, then there's no rush or panic to have sex again. And one of the things I was taught many years ago is to actually try not to have sex. That sounds a bit weird, but almost like you're a teenager again. You can explore each other's bodies. It's not just about having penetrative sex. So if you've not held hands for years, if you've not given each other a hug for years, if you've not kissed for a long time, do that, but have boundaries and say we're not going to go any further. So then eventually when you do come to having intimate relationship and penetrative sex, it will feel completely different because you're not pressurizing yourself when you have a small amount of intimacy in your relationship, when you've had a long time without sex. The other thing before I end is thinking about the partner. So we're very good at just talking about the person who's affected. But actually, many people I speak to, and I know this, especially with my husband being a urologist, is that the women might have been transformed and improved, their libido comes back, they have no physical problems or symptoms, they've got no vaginal dryness or soreness, but it's been so long since they had intercourse that their male partner is impotent or has erectile dysfunction. And so they might not have spoken about it and actually been quite relieved that they're not having sex because they can't get erections and they're finding they don't have libido as well. There are treatments for men as well, and so we need to include them into the conversation and think about that too. It's often harder for men to seek help, but it's also easier often for them to get help as well because you can buy Viagra over the counter. But often if people are having erectile dysfunction, they should be seeing a doctor because it could be a marker of some cardiovascular disease, there could be other things going on. So really important that we work together, and as healthcare professionals we are trained to give information and advice and treatment to as many people as possible. And if we can't, so in my clinic obviously I don't prescribe a treatment for men, but I do know how to recognise if men are having problems and difficulties, and I can certainly signpost to the right people and healthcare professional. So if you feel that you can't talk together as a partner, use another healthcare professional, whether it's a GP, a nurse, a pharmacist, a psychosexual counsellor, a therapist. Just talk about things and realise that you're not alone. Many people have relationship problems that really come to the surface during the perimenopause and menopause, and there are plenty of treatment choices and options as well. So I hope that's been helpful for you today. Next Sunday I'm going to be talking about bleeding, and that will be related to either the perimenopause or for taking HRT, because there's a lot of women who find that their bleeding pattern becomes more erratic, periods become closer together, maybe heavier, and also once they start HRT, bleeding is a very common side effect actually, and there are treatments that we can do to help. So I'm going to talk about that. If you've got ideas for other Instagram lives on other Sundays, then put them in the chat when I post this on my grid, and look forward to seeing you next Sunday. Have a good week, and I hope you do enjoy Valentine's Day after all my chat today. So take care. Thank you.